Good afternoon, everyone. Welcome to the Penn State College of Medicine COVID-19 and Regional Skilled Nursing Facilities ECHO series. We're delighted to have you join us for today's session. My name is Jackie Sable. I'm a member of the ECHO team. I'll be facilitating today's session. A few quick announcements before we begin. If you've not already done so, please put your name and email address in the chat function for our record-keeping purposes. We ask that you stay muted unless you're speaking. You can use *6 if you're dialing in, or the microphone icon on your Zoom screen to mute and unmute. You may also use the chat for communicating throughout the session. We definitely encourage the use of webcams, but we understand if you're not able to use one. We realize that question and answer time is important to you, and we do try to address as many questions as we can, and we'll try to categorize them as well. But if there are any unanswered questions afterwards, we always follow up with a Q&A document that will go into your participant folder afterwards. Please remember that if we do discuss any cases that no personally identifiable information or PHI is allowed, we are recording these sessions and we share all materials and recordings after each session. In the spirit of ECHO's all teach, all learn approach, we're on a first name basis during our sessions. So today's session will include a brief lecture on the role of the medical director by Dillard Elmore, and that will be followed by discussion and question and answer. So during the lecture, please feel free to put your questions into the chat. We do have a team of specialists online, and they will try to address things through the chat, but we'll also come back to those after the lecture. But please remember that this is all teach, all learn, so everyone can share both questions and answers. In the interest of time, I'm not going to ask everyone to introduce themselves, but I will be turning this over to our lecturer, and he can introduce himself as we get started. Thank you.
Good afternoon, everyone. My name is Dillard Elmore. I am the Senior Vice President with Diakon, and I'm also the Corporate Medical Director of Diakon Medical Group. I also chair the Pennsylvania Medical Directors Society Association, which is the Society for Post-Acute and Long-Term Care Public Policy Committee. And I'm very honored to be here presenting the role of the medical director. So we could.
Are you able to see my screen? Can everyone see the slides?
Yeah, I can see the slides.
Perfect. You just tell me next slide and I will keep going.
So I have no disclosures. We can go to the next. So the objectives. I think it's important for me to provide a clear understanding of what the role of the medical director is in post-acute and long-term care medicine. To offer some insight on how a certified medical director can be an asset to your organization and their goals, and to promote better collaboration between clinicians and administrators in post-acute and long-term care medicine. So what is PMDA? So PMDA, as we call it, is the Pennsylvania Society for Post-Acute and Long-Term Care Medicine. It has medical directors of nursing facilities, chief medical officers of post-acute and long-term care chains and health systems, attending physicians who may be geriatricians, internal medicine doctors, or family practitioners. We have nurse practitioners, physician assistants, practice managers, and allied health professionals such as psychology, social work. So we're all inclusive. Next slide. So some of you may be saying, so PMDA is just a group of medical directors. Why do we need this presentation? Well, I think the role of the medical director, it seems self-evident, but it's really not. I'm a board certified geriatrician, and I have to tell you, once I joined PMDA and AMDA, I developed a clearer understanding on what the role of the medical director is. So under the Nursing Home Reform Act of OBRA 87, this role was formed. Before that, there was really no medical director role in any of our long-term care facilities. The mandate was that every facility must have a physician medical director. Now, this medical director is not someone who is contracted through Part B. They're not being paid by Part B because this is an administrative role. So this is someone who's contracted directly with the facility, and there's no requirements for the hours worked or the time they spend at a facility or how many facilities they serve, as it was presented under OBRA 87. No national training was required. Now, this role is important because there is an F tag related to not having a medical director, and that's F tag 841. The medical director is expected to take the lead on the overall policies and coordination of care for all of the residents in the facility. This role is complex. As many of you know, our industry is said to be only second to the nuclear industry when it comes to the amount of regulations. So the role of the medical director is really important, and having someone who understands the stresses of post-acute and long-term care medicine is extremely important. To that end, the American Board of Post-Acute and Long-Term Care Medicine certifies medical directors. And this basically gives a physician who completes online and in-person coursework the added certification of a certified medical director. We go to the next slide. So let's compare and contrast medical director versus the attending physician. The medical director may also be the attending physician. But as stated earlier, the medical director role is purely administrative. It's not a clinical piece unless it's caring for a resident who has another attending that, hasn't been able to take care of that resident, or there's something that the facility needs. But they're contracted directly with the facility and paid through the facility. They're responsible for the overall patient care, and they're part of the facility's leadership team. And I think this is something that needs to really be driven home. I've worked at facilities, especially early on in my career, where the medical director was a GI doctor who the only credential was that they did a lot of procedures and referred a lot of residents to the facility. I've also worked at facilities where the medical director was a pediatrician. So, great pediatrician, but really didn't know anything about what the nursing facility needed and the constraints and, length of stay, return to hospitalization, how to deal with the geriatric population. So nowadays, there may be some acute hospitals that are just allowing their attending physicians to drive referrals, but overall, a lot of them are looking at the metrics and what is the quality that you're getting. An attending physician bills via Medicare Part B E&M codes. The attending physician is required to do the initial comprehensive assessment, and that's CPT codes 99304 through 99306. Now, it should be noted that an attending physician can work with a nurse practitioner or a PA who actually sees the resident, the new admit, before that attending, but that nurse practitioner or PA cannot bill that as an initial visit, and they cannot use the 99304 through 99306. In normal times, there's the blanket waiver where there's some leeway with that, but under normal circumstances, those codes are only for a physician, an attending physician. Next slide. So as we see with the beautiful novel coronavirus 19, having a partner who understands your environment is extremely important. I know that as early as January and February, I was hearing the buzz throughout my connections in PMDA and AMDA about the coronavirus and how, people were concerned. And when it hit Washington State, within a few days, I was on a call with medical directors who were part of AMDA in the Washington State chapter of the Society of Post-Acute and Long-Term Care Medicine. And we were hearing firsthand the issues, some of the issues we never thought about. Aerosolization. We didn't know. There was no CDC, recommendations on aerosolized interventions such as nebulizers, such as, CPAP, BiPAP. I learned about this from my colleagues in Washington State, who noted that a lot of the nurses and the medical staff that caught COVID-19 were giving nebulizers to individuals, and they thought that this may spread it. So my organization and other partners in PMDA, we were able to, ahead of the game, get rid of nebulizers where they weren't needed. So we are able to dig into a beautiful resource pool of individuals who've been there, done that. We can share thoughts and best practices. I also remember that in June, I received a call from a medical director who found my name on one of my campuses. And this was a medical director who was in Central PA, and he was concerned. He wanted to basically, get together a group of local physicians and medical directors to prepare themselves for COVID-19. Now, this was June, and I have campuses that are also in Eastern PA that are bordering Montgomery County, which was the hotbed of Pennsylvania early on. And, I was living COVID-19 and treating COVID-19 since March, and getting some best practices since February from people all over the country. And I informed that physician, why recreate the wheel? The wheel is already there. We have power steering. We have everything that you need. There's no need to try to go it alone. We need to, you need to be able to share this information. And PMDA and AMDA is the organization that has certified medical directors who have this knowledge. Next slide. So what we see is that there are several publications and resources that PMDA and AMDA utilize. So AMDA puts out the Journal of Post-Acute and Long-Term Care Medicine, which is JAMDA. There's also a podcast for those of you who are on the go called AMDA On the Go. And this podcast sometimes has 15-minute in-services, or even longer, going into different topics that are, diverse concerning post-acute and long-term care medicine. And it's always there to keep you fresh and up to date. The Pennsylvania Society for Post-Acute and Long-Term Care Medicine puts out an e-journal. And there's also the Geriatric Journal Club, which the American Geriatric Association and AMDA have combined to actually put together, hot topics, that come up in the American Journal of Geriatrics, and discuss them. And I also have my organization, Diakon Medical Group, which is a SNFIS group that's 100% dedicated to post-acute and long-term care medicine. throughout Pennsylvania and Maryland. Sorry, next slide. So in summary, having a certified medical director as part of your leadership team has benefits. And the key thing, I know last week, Mike Wasserman, who's part of AMDA, he stated that it's important to make sure your medical director is part of your leadership team, especially when we're dealing with major challenges such as COVID-19. But that medical director should also understand what that leadership means and what your stressors are. I would say encourage your medical director, your NPs, your PAs to join PMDA and AMDA. We have so many resources, and we desire to share it. We desire to see the state of Pennsylvania have extremely low mortality from COVID-19. And there are best practices that can be shared. There's no need to go it alone. And the knowledge is there. Just put your hands out and we'll help you as much as we can. Encourage your medical director to earn a CMD. And I cannot stress this anymore. I am a board certified geriatrician, and that taught me how to be a solid geriatrician. By joining PMDA and AMDA taught me how to be a medical director. And there's nuance that I would have never guessed, and I was able to learn. So I think that's the last slide. And if anyone has any questions, feel free.
Thank you so much for that. I know we have a few members of our panel online, so I don't know if either of you, I see Gavin and Aisha are online. I'm not sure if Nikki's here. Do you have any questions for Dillard before we open it up to our participants? So, Dr. Osvaldo.
I can actually, I'm sorry, I'm on my phone. Thank you for the presentation. I think I might have actually been the one that requested this to hear from a medical director. And the reason being, you know, as my team has gone out to sites with outbreaks, we've seen a very mixed level of engagement from the medical director. And the sites that have had the most struggle were the sites where even after me calling, the medical director just would not engage. They would say, oh yes, I'm checking on the patients, but they were not part of the facility plan and how they were going to manage. I've also been surprised with the lack of knowledge about how facilities manage COVID, you know, green, yellow, red zones, PPE usage, rules about staff returning, line lists, when to come off of transmission-based precautions, things that I think, you know, medical directors get a stipend, and I've been disappointed in some kind of checking out and the facility is out there on their own. And then others that honestly, without their medical director, I think the facility leadership would have crumbled, but because the medical director stepped in, it made a remarkable difference in the ability of that leadership to kind of pull themselves together and lead their team through the crisis. And so I think I wanted to ask, you know, from your perspective, what should facilities, nursing homes expect of their medical directors? Is this okay that they're stepping back when their facilities kind of in major crisis? Should they all be aware of, you know, what the guidance is and be available to run line lists, understand PPE, advocate for the facility if the corporate leadership isn't stepping in. What should nursing home leadership be expecting of their medical director when there's an outbreak? And I'll stop there.
Well, Nicole, and thanks for that question. I would say back in the day, which is maybe 10 years ago, a lot of nursing facilities just looked for individuals who could drive their admissions. However, the Society for Post-Acute and Long-Term Care Medicine realized that there needs to be a medical leader, not to lead the organization, not to lead the facility, but to be part of the leadership team. And, what I can tell you is what we did at Diakon Medical Group is we partnered many long hours with the senior leadership of Diakon Senior Living Services and Operations. And we developed, with my input from what I was hearing over in, Washington State, California, Florida, New York, we distilled a lot of best practices into what we call the guidance. And it's the Diakon COVID-19 guidance. And this is a document that it's a living document, meaning that it grows and evolves with each CDC guidance that comes out, or each, Pennsylvania HAN, guidance that comes out. We were able to evolve it. And sometimes we were able to look at best practices. I know we spent hours going over how to deal with CPR in COVID-19. Now, I wouldn't have thought about CPR in COVID-19 or even the nebulizers and things of that nature if I didn't hear from my partners on the West Coast who were dealing with this. So I think, first off, facilities need to be clear on what do they need from their medical professional, right? Do they need a partner that's going to keep them ahead of the curve, right? Do they need someone that is going to be tapped into a deep network of individuals who are dealing with every diverse issue that can face a clinician in post-acute and long-term care medicine? Are they willing to make that person part of their leadership team and to work together to come out with the best policies and procedures? So I say, first, understand what do you want and what do you need, as COVID-19 has shown us. You need the facilities need a partner that can support them. And then what do you expect? I would say expect someone who is getting some training. I would encourage them to get their medical director to join PMDA, to join AMDA, to get some training in post-acute and long-term care medicine. As a matter of fact, I would say if you're not getting that, we have throughout the state, we have certified medical directors and different members who would be more than willing to support. Diakon Medical Group, for one, is dedicated 100% to long-term care facilities. And, this is all we do. We certify medical directors and we go to the facilities and give support. So I know that was long-winded.
Thank you. I think that helps. I guess I also wonder, from your perspective, would it be helpful if, from a leadership level, if there was a punch list, for example, in readiness for COVID, and if there was, many sites have daily huddles, if not weekly huddles, that the medical director is required to participate in, be actively involved and understand what's happening in the building. I've had some medical directors, one just texted me now with a question. I've been working with her for a month. I had another one on the phone on a Saturday night with their administrator with questions. And then, like I said, there are some that are really not engaged at all. And I don't know if the administrators feel empowered to request this of them. So I guess, what I wonder is, if you were an administrator in a building and you had a medical director who, did a good job taking care of their patients, but now your building is in crisis and you really need them to take on that medical director role, beyond the resident care. How do you engage them? Do you bring them in on routine meetings, so that when there is crisis, they're up to speed and understand what sort of knowledge base they need to be able to bring to the table when there is a crisis? Do you, require of them something else? I guess, from an administrator perspective, I felt in the cases where I tried to get the medical director to engage, the administrator didn't really know how to go about getting them to be engaged in that way, because they really were kind of more patient care focused. So I don't know if you have any advice for us on how an administrator or DON would help a medical director understand, they need to have a larger role when it comes to COVID.
Well, it's all about onboarding with anything. Remember, the medical director, that is an administrative role. So if you bring on a physician who is basically expected to drive referrals, then that's going to be what that physician expects to do. And they're probably going to have other practices. They may have an outpatient practice that's bidding for their time, and they're not going to necessarily want to become that engaged with something that could be sticky while they're trying to, manage their other duties. So I think letting your medical director, when you vet them and you choose them, first choose wisely. Choose someone that knows that they're coming in to be an administrative role, that the medical director role is administrative. I know certain facilities that have a medical director who's only administrative and doesn't have any a clinical panel. So you need to do that when you're onboarding. But obviously, COVID-19 didn't just gently come into our lives. It basically crashed into that. And I think that those administrators need to have a frank conversation with that medical director. And the medical director should be aware that, those are actual billable hours that they can utilize, and see if that medical director, once they're at the table, do they have something to provide you with? As I stated earlier, I had a call in June from a medical director who appeared to be very concerned and very caring about his population, but he had no connection with PMDA, AMDA. COVID-19 was brand new to this person in June, whereas medical directors who were part of that network of PMDA and AMDA, they were already putting out best practices since March. So onboard your medical director correctly. See if that medical director, what are the resources they're bringing? Do they have some training in post-acute and long-term care medicine? Do they understand what your straight stresses are? What are their resources if a curveball comes your way, right? And if they can't provide that, then maybe you continue the same relationship as an attending physician, but maybe you should look for another medical director who actually understands what you're dealing with, and invite that medical director. One of the key things is sometimes, I hear this even myself, well, we know you're busy, Dr. E. And, but no, invite your medical director. If you don't invite your medical director, he or she will not know what's going on. So you have to put them at the table to be a better source to you.
So there is a comment in the chat box. Daryl, if you'd like to unmute and read that, you can. If not, I'll read it for you.
Can you hear me?
Yes, we can.
Okay. The bottom line is when I was in private practice and I was functioning as a medical director at one of the major corporations, I did both. I was the administrative medical director that gave guidance around different processes and procedures and policies and trying to make sure that they kept good quality of care. But also part of my function was that I gave the right kind of service to the residents and also had that developed that relationship with the hospitals so that we had a lot of referrals. I mean, we used to get somewhere between 50 to 70 referrals a month for new admissions to a skilled unit that I was the medical director. And on top of it, I helped them to maintain good quality. So you can do both.
Well, yeah, I agree. I do both. I'm the corporate medical director for an organization that has 9 facilities between Eastern Pennsylvania and Maryland. However, we always have to keep in mind that not every location is the same. So some locations may be they may be very rural. And so, you know, I believe that they should be able to do both. However, you know, we always have to keep in mind that there are different circumstances everywhere.
Well, thank you for sharing that, Daryl. Are there any, excuse me, other questions or comments, either for Dillard or anyone else who's on the line?
I wonder, does anyone have any best practices to share in how you have engaged with? I know we heard a bit from Diakon and how they established their kind of COVID playbook. Does anyone else have any best practices, lessons learned, whether it's from how, from a medical director perspective, you know, staffing, which has been a major challenge, you know, if there were any successful efforts in how we preserve the current workforce in our buildings, to, you know, setting up guidance for the COVID testing, the different zones. Just curious if anyone on the line has any, you know, best practices or stories to share.
Thanks for that, Nikki. So I'll wait a few moments here if anyone would like to unmute their microphone, or feel free to put it into the chat. But if you can unmute, that would be wonderful.
Well, this is Janice Whitaker, and I'm with the Penn State College of Nursing and was a former director of nursing. Just a few comments in relation to developing, you know, setting expectations and really engaging the medical director as part of the leadership team. Some of my experience has been that in some facilities, as Dillard was mentioning, I think some facilities approach it from, you know, meeting regulatory standards in terms of admissions, referrals, getting assessments done in a timely way, you know, from that resident or patient care perspective, rather than really engaging the medical director with the leadership team. And one way we worked on that was through better communication about when we were having our quality assurance meetings, inviting the medical director to the table to provide reports, to hear what our concerns are, to get their insights and perspectives, especially with policy development, and but also to hear, you know, what was going on, you know, around staffing, around family concerns, and other things that they could have some input into. But I think it's really about what happens during that contact it's about the onboarding process, I agree as well, and setting expectations during contract negotiations, and then making sure that there is the proper facilitation and support for the medical director to be involved in that capacity, because of course they are usually coming from an outside organization and have other responsibilities as well. So it's really about building that relationship, communication, as well as setting those expectations.
I agree. And sometimes the medical director may not know the role, and so they don't have much to add. So getting them those resources to basically understand the role better is also something that's easily remedied.
Yeah, and I think it has to do with culture change and, you know, kind of the evolution of care communities and the involvement in everyone on the team.
I think also, you know, just recognizing right up there with the DON and the NHA is the medical director. And I often find when I engage with the site, there's a dyad, not a triad. And that's, you know, I think something that early on establishing that expectation, so that you do have that engagement and awareness, situational awareness is so important. I think COVID has brought it out, but I think being an area where we often and maybe neglect to bring in the medical director when really it should be seen as a triad of leadership rather than a dyad.
If I can throw in a comment, thank you so much, Dr. Elmore, and thank you, Nikki, for your observations. I'm not a medical director at the facilities that I work at on behalf of Penn State's Post-Acute Care Network. And I think in the age of COVID, the thing that helped the most were daily huddles or huddles that subsequently eased back to once or twice a week. Both when the pandemic stopped you know, nationally, and then also when the pandemic arrived at our facilities. And I think sometimes the other medical teams that are not necessarily affiliated with the medical director may have had an experience or may have the academic backing like we did to really help with the outbreak and infection control. So I feel the medical director also needs to look at everyone as an ally and help make this whole process seamless rather than polarized. But I feel that the daily huddles were probably one of the most important things we did when we fought outbreak at the facilities that at least I work at. I'm not sure what Dr. Elmore and Nikki have to say about that.
Yeah, well, having that team prepare is always a good thing. A lot of what we did was in advance, just, you know, early on, and I'm sure you guys are involved with PMDA and AMDA as well. You know, was listening to what, you know, Sabine or, you know, Mike Wasserman or Dave Nates or someone else was talking about, you know, different characteristics and traits that they've seen in preparing. I know that we were cohorting very early on, and that's, you know, that's that muscle memory that you have to build, which is not normal. You know, COVID has forced us to do things that aren't normal. And we're going to have to continue to build that muscle memory. And I've seen facilities that really buy into that. They do better. And, you know, like yourself, Dr. Ahmad, you know, being someone who is a very, you know, knowledgeable, physician in post-acute and long-term care is also an asset, because you've been practicing infection practices and controls and antibiotic stewardship and things of that nature. And that's important. And, you know, those small things that helped organizations but weren't that glamorous before COVID-19, they've turned out to be majorly impactful when we're pushed to the limits on stressors, like a once in 100 years pandemic.
And I would kind of add to that, with the daily huddles came some recommendations that were not business friendly, like preserving 2 rooms for a red zone so you can quickly cohort, and things that, you know, if it was up to, you know, the financial side of the facility, you know, they may look at it and say, oh, there's no way. But, you know, when you have the team come together and examine all of the aspects, items like that, you can have a frank discussion about, you know, the purpose, and, you know, as the medical director, have an understanding of how that financially impacts the business, but then also state your concerns regarding, you know, why it's necessary. So I think on many levels, the huddles were really important, because we would come to find out decisions being made that were looking at it from one perspective, and perhaps with that perspective not having the full view of what was happening in the building and the limitations of what the staff could do with the guidance that was out there. And then your medical director becomes an ally for the DON and the administrator, who might be reporting up to someone else who isn't kind of in the thick of things, isn't intimately involved with the staff and all of the, you know, the activities that transpire when you have a COVID outbreak in the building.
Yeah, that's a great point, Nicole. You know, having a medical director partner who realizes that they're not the boss of the table when they're at the table is important, because we have different perspectives. You know, as a physician, you know, I want everyone to live to be 150 years old and, you know, run marathons, but that's not necessarily realistic, or it may be, you know, prohibitive. So having everyone at the table, sharing their perspectives, and coming up with a consensus that keeps your facility's doors open, decreases, well, I shouldn't have said that first, but first, decreases the morbidity, mortality to your residents, keeps your doors open, because you can't have a mission if you don't have revenue, right? I mean, there's no mission without that. And, you know, that's just important. We have to work together as a team and understand one another's perspectives.
Yeah, I get that part. I guess what I confront, you know, is when I have facilities saying their PPD is, you know, 2.7, they're taking admissions, they have a COVID outbreak, you know, there's cries for help, and it seems like at the leadership level, it's kind of like, okay, business as usual, you know, like there's a real disconnect. And, you know, again, I think as a medical director, you know, you're not only responsible for, you know, I understand some of them play the role of, you know, kind of keeping the beds full. But when you have a full on outbreak in a building, perhaps because there were missteps at the beginning, because small sacrifices weren't made, it really explodes. And that's where I think, you know, having a really knowledgeable medical director to kind of balance, and I totally get what you're saying, you need to have people in beds, but really balance, you know, the staff safety, patient safety, you know, the business aspects, what needs to be done. You know, amidst all of it, it really can't come from one person. And, you know, the people that are on the ground are our staff, you know, and even in some cases, I had medical directors that hadn't stepped foot in the building since the outbreak began, 2 or 3 weeks, and they're doing virtual visits. And I understand maybe they have to be in a clinic, but they're also not in a, they're not well positioned to be able to advocate on behalf of the staff and the patients, because they're not physically in there. And, you know, for those of us who are in the sites with outbreaks, you know, the staff are anxious. You know, everything just requires a bit more effort and time. And I think sometimes you know, what I've seen is kind of a disconnect. And then there is, you know, usually there is some sort of epiphany at some point from the leadership, like, okay, we can't keep going business as usual. But I think a recognition of that earlier on would really take the temperature down a few degrees for the staff that are kind of in the heat of the battle every day, trying to, you know, manage and balance the new admissions with, you know, the needs of the cohorting and the PPE. And, you know, I just have seen that firsthand, and get concerned sometimes that maybe there's not good communication between the very, very highest levels and then, you know, the frontline staff.
You know, there is a certain amount of credibility that an engaged medical director brings. You know, I know that what we've seen with COVID-19 is that, you know, worst case scenario, as soon as you get your first case, you'll lose your DO and your ADON. I've seen this. They'll just quit, and you'll have your CNAs, you'll have everyone just leaving. And if you get ahead of that with an engaged medical director and you know, go through what COVID-19 or whatever we're dealing with in the future is, how do you protect yourself? How do you protect your children? Are your children at major risk? What can you do? As you guys can see, I'm wearing scrubs right now, and that's not for me, it's for my wife. You know, I basically wear scrubs, and I, you know, don't wear them throughout the house. But having a medical director that can go through some of the basic science of what's going on, what the rationale is for cohorting, what the rationale is for, you know, different zones. I know the nurse, you know, and there's shortages of nurse, but the nurses that had to be in the red zones, that, you know, can be something, a point of real concern. And it's funny because, as you guys have probably seen, Nicole and Aisha, that, you know, initially that's a major problem, but you come back, you know, a few weeks into the outbreak, and a lot of emotions and nerves have calmed down. People are getting used to, you know, wearing their PPE, donning and doffing of the PPE, hopefully correctly. That's important. You need that engagement, and you need someone willing. The facilities need someone who is willing to learn and to adapt, to be a better partner, because there's no growth if you don't have anyone that's willing to adapt with you.
Dillard, this is Janice again. I really agree with what you just shared in terms of the credibility of that medical director and the level of calm and reassurance that the medical director can provide, not only to the leadership team and to the staff, but to the residents themselves and family members. I always remember, we could always tell when the medical director was in the facility, because there often was a line of family members or residents waiting to see him. And we sometimes, when we had a flu outbreak several years ago, which, you know, was just a little taste of what everybody is experiencing now, our medical director met with our staff, you know, did some educational programming along with myself as the director of nursing and our staff development coordinator, that, you know, provided not only accurate information, but just an opportunity for everyone to ask questions and get answers, and offered that the same for family members too. And I think that was very instrumental in calming everyone's anxiousness.
Thank you, Janice. I don't want to lose what was going on in the chat. So those who actually listen to our sessions afterwards may not see the chat in the recording. So Janice, you had asked the question, are medical directors present during daily huddles? Many skilled nursing facilities do not have medical directors present daily, but they may have a PA or an NP. Aisha mentioned that 2 of her facilities that they were present for the huddles. Dillard said the CRNPs are available. Gavin then talked about his 8 facilities that he has worked in. They were kept separate, but they participated in video meetings as part of the team. But the risk was too high at that point for them to be coming into the facility. So then Janice brought up, there could be innovative ways of including the medical directors on a daily basis, such as with technology. So if anyone has anything else to share in terms of, how you may be including your medical directors on the daily huddles, or, if they are present or not, feel free to share that either in the chat or unmute. So are there other questions or comments? We have a few minutes left to address any other questions or comments.
I'm just wondering if, if Dr. Osavala or Dr. Elmore can shed light whether they noticed a trend that medical directors from large franchises are more engaged versus medical directors of, single facilities, regardless of size. Was there any correlation, or do you feel it's random?
Well, Dr. Acevella would know better.
I mean, I can speak. Oh, go ahead.
I think it's variable. I think it just depends on the medical director.
I don't see a pattern in who is engaged versus not. Even rural versus, I would agree that when they are involved, it makes a big difference.
Okay.
I think it goes back to just the facility. You needs to really pick wisely. And as Janice stated, there are creative ways. Remember, the medical director role is an administrative role. So if you can't find anyone that would engage with you and can not come daily physically, you can maybe look for someone, if you're in a rural area, that may not be as close to you, but that can provide you with some leadership, even through tele. There's ways of dealing with that.
Okay, so it looks like there was no correlation between large franchises versus freestanding, single facilities. Thank you.
Well, that is, and I'm not trying to make a plug, but that's why we started Diakon Medical Group at Diakon. What we saw that there was a huge variability between the care that the skilled nursing facilities were receiving, and we wanted to make it more uniform and have individuals who were purely dedicated to post-acute and long-term care medicine. And that's Diakon Medical Group is purely a SNFIS organization that's skilled nursing facility oriented. This is all we do. We take all of our own internal call. So whenever there's a call at night, it's going into someone who wants to be in the skilled nursing facility or assisted living or independent living, and not someone who doesn't want anything to do with post-acute and long-term care medicine, and their first response is send them to the hospital. So that's what we've done. And the medical group now is basically expanding, to, we're available throughout the state of Pennsylvania to support campuses that may want to partner, because this is a passion of ours to basically improve outcomes.
Thank you for that. So I'm going to ask Dillard and Gavin, Aisha, and Nikki, do you have any final comments before we wrap up for the day?
My final comment would be, don't be afraid to engage your medical director and expect, expect from them that you can get expertise in the, particularly in the age of COVID, related to it. And if you feel they're not comfortable, then just say, in the next meeting, this is what, we'd like you to help us with and guide us, and allow them some time to prepare. But I don't think it's unreasonable for nursing home administrators and directors of nursing to expect that of their medical director, and don't be afraid to ask them to be engaged, particularly when you have an outbreak and you really need that third man or woman on board, guiding your facility through a difficult time.
And I think Jackie, if there's one thing that we are seeing in 2020 is this evolution of decision making and management, where maybe in 2019 it was a very top-down hierarchical type organization, where I think as Dr. Elmore clearly sort of mentioned numerous times, and both Nicole and Janice have mentioned this as well, and Aisha, is that it's that more of that team building. It's more of that participation in decision making. It's more of that acknowledgement of decisions are being made at different levels, and they're being made for really important reasons. And instead of just waiting to be told what to do, it's actually to identify the challenge, the problem, the situation, and come up with ways to mitigate those risks and those situations you find yourself in.
What I would say is expand beyond someone who you feel is going to give you more patient flow. Look for someone who our facilities, we have to look at gradual dose reduction. We have to look at antibiotic stewardship. There are so many things, falls, over-treating hypertension in the elderly and frail. There's so many things in our complex environment. You need a partner that understands that. And, PAMDA, AMDA are great resources. We want you to succeed. and if your partner does not want to be a partner, then there are other clinicians who are involved in AMDA and PAMDA who would be willing to support you. So you have the power.
So thank you for that. Aisha, any final comments before we wrap up?
I think I'm good. Excellent discussion, everyone. Thank you.
Yes, thank you, everyone. I did put the evaluation link in the chat, but you will receive an email which also contains that evaluation link. Your feedback, whether you're requesting CME credits or not, is extremely valuable to us. Please also watch. We'll share the YouTube video channel with you and our participant resources. And we will see you again October 29th at 2 p.m. when Dr. Asavala will be back and discuss lessons learned in visiting facilities. So thank you all very much.
Thank you. Goodbye.
Thank you. Bye-bye.